So, good morning everyone, and at the outset let me congratulate GVK and the team of 3D for this particular meeting, and thank you very much for this invite. We are enjoying since morning a lot of good discussions and debates, but hypoglycemia is one thing which also precipitates a lot of irritability, a lot of anger inside you, and it's better that we should. I'll just share with one of the story. One of our very senior professor, I feel Dr. Ekidas knows him. He was a diabetic and he was multiple doses of insulin, and suddenly he used to behave abnormally during the rounds. And then some of the senior professor who knew about it, we were residents, he used to take him away to the RMO room and make him comfortable. And then those days, I'm talking 30 years from now, Professor S.K. Katenois, unfortunately we lost him. The greatest limiting factor is hypoglycemia for management of diabetes. I'll try to cover with symptoms, with different types of hypoglycemia, risk factors, and the treatment part. There is also some unique or a newer topic which is hypoglycemia in pregnancy. I'll just try to cover in 2 minutes or so. To define hypoglycemia, it's a biochemical condition resulting from an abnormally low blood glucose levels, which is usually less than 70. For infant, it is less than 30. And the important is we will try to go through these different evidences, and then pregnancy I'll cover a little later. What are the evidences we have? DCCT trial in type 1 diabetes or UKPDS trial in type 2 diabetes have classically shown the moment you go for intensive therapy in a given case, you end up with increasing the risk of hypoglycemia. It's management is like a tightrope. You want to achieve a good glycemic control without increasing the risk of hypoglycemia. That is what is an art of a good diabetologist or endocrinologist. And this again another HAT study, very recent trial data from Dr. Kunti, which again has shown that on an average the hypoglycemia in type 2 diabetes in around 18,000 patients comes to around 20%. And as it was discussed, diet, metformin, usually or the DPP-4 inhibitors or SGLT2 inhibitors, they don't increase the risk of hypoglycemia. It's a minimum risk of hypoglycemia. Sulfonylurea, insulin, basal bolus therapy, the risk of hypoglycemia goes on increasing. I'm thankful to GVK for providing his own slides where he delivered one lecture on hypoglycemia. So I have actually incorporated few of his slides here. Diagnosis of hypoglycemia, it's called as Whipple's triad. You have to have symptoms of hypoglycemia, you record blood glucose as low blood glucose, and once you correct it, you get a benefit. That is how you call it as hypoglycemia. There are different symptoms. I feel everyone of delegate here knows about it, that we have first is adrenergic symptoms or the neuroglycopenic symptoms. You'll have sweating, maybe palpitation, tremors, hunger. Neuroglycopenic symptoms start little later. You will have confusion, drowsiness, difficulty in or the slurring of the speech, incoordination, atypical behavior. Now, they're non-specific and the symptoms can be non-specific. Sometimes I usually explain to the patient the symptom which you have never expressed or never felt earlier. And if you have started feeling after starting a new drug or diabetes, anti-diabetic therapy, you may presume it as a hypoglycemia, try to diagnose, try to document it and treat it. So it can be individualized. There will be inter and intra-individual variations in the symptoms. If you have a sudden fall in the blood glucose, you'll have adrenergic symptoms. If you have a gradual fall in the blood glucose, you might have more of a neuroglycopenic symptoms. Now this is a hierarchy of the fall in the blood glucose. When it is around less than 80, your insulin secretion starts coming down. When you are less than 68, your counter regulation starts coming up, glucagon goes up. Your symptoms of hypoglycemia start when you are around 55. Your cognitive function starts getting affected by around 45, and you may end up with coma by around 30 mg/%. And this is a counter regulation. First is insulin concentration falls, glucagon starts increasing within minutes of the hypoglycemia, then it is being taken care by catecholamines, then cortisols and growth hormone. And this is just how the hypoglycemia precipitates or stimulates the other counter regulation through glucagon, vasopressin, growth hormone, cortisol, adrenaline, and they all come out with for correction of the hypoglycemia. What are the causes? Causes are simple. There can be fasting hypoglycemia, there can be postprandial or reactive hypoglycemia. Now fasting hypoglycemia is because of the reduced glucose production due to maybe hepatic disease, chronic kidney disease, deficiency of the some of the counter regulation. Maybe sometimes it is alcohol related, sometimes salicylates, sometimes beta blockers. You will come across someone, there was a drug which was called as getifloxacin. This drug used to have severe hypoglycemia. Many patients who are already on good drug, good control, suddenly come to you, sir, I'm getting hypoglycemia since 3 to 4 days. I had a dental pain, some toothache, and my dentist had given some drugs, and they are none other than some of the NSAIDs. So you need to be little careful on this. Increased glucose utilization, maybe insulinoma, sepsis, insulin releasing drugs like quinine, pentamidine, some of the tumors, very exhaustive exercise. Sometimes it can be artifactual, could be taken by some of the, one person gave an example of 50 tablets of Dr. Lakshman, I feel, of sitagliptin, nothing happened. So of sitagliptin, I was just saying, what was the purpose? Whether she knew that must be usually they are when it comes to suicidal attempt. So if she possibly might be knowing that it does not cause hypoglycemia, or if suppose she was not aware of it, then possibly the drug had ditched her and it did not work. So, yeah. So the postprandial hypoglycemia, reactive hypoglycemia could be because of the bariatric surgery, hypothyroidism, idiopathy. There are various kinds of pre-diabetics. Pre-diabetics may present to you postprandial hypoglycemia. There are various predisposing factors. If you are starvation, fasting, weight loss therapy, sometimes weight loss diet, renal hepatic dysfunction, I told you, alcohol abuse, acute illness, some of the treatment errors. Someone has written, I have seen one slide, some other topic, someone has written 6 units of insulin, and the nurse has read it as 60, and they give 60 units, and it landed up with hypoglycemia. So such things are not uncommon. I'll also show you some other examples here. Consequences of hypoglycemia: it can cause glycemic variability, it can overall hypoglycemia, nocturnal hypoglycemia, severe hypoglycemia, it can precipitate MACE. All-cause mortality have been documented to be in type 1 as well as in type 2 diabetes. And we have ACCORD, ADVANCE, EXAMINE, ORIGIN, LEADER, DEVOTE. All these trials have shown that the hypoglycemia may increase cardiovascular morbidity, and there are various mechanisms which have been proposed: endothelial dysfunction, inflammation. This endothelial dysfunction and inflammation may persist up to 48 hours, while the coagulation abnormality and sympathetic overdrive might exist even up to 7 days. QT prolongation is another very important thing which gets precipitated because of hypoglycemia, and this again has been shown. And there is one important terminology which is called a death in bed. And everyone knows about it. Death in bed has been hypothesized to be because of hypoglycemia. Let me share with you, there's only one case report in the world when the patient was on CGM, and it was documented that the person who was on CGM died on bed, and it was documented to have hypoglycemia. Now I hope it would have been CGM. Along with CGM, they would have had even the monitor, the pulse monitor or heart rate monitoring. Possibly it could have been documented, even QT prolongation. Severe, even silent hypoglycemia may induce cardiac arrhythmias. You talk about silent myocardial infarction. So silent hypoglycemia may also precipitate cardiac arrhythmias. That also we have to look into. Brain and blood glucose. Now brain is very sensitive to hypoglycemia. Glycogen reserve in brain is very little, lasts for only 2 to 3 minutes. Brain utilizes almost 120 gram of glucose per day. It can't utilize alternative substances like free fatty acids or amino acids, unlike other organs, and hence brain is very much dependent on the blood glucose. Brief hypoglycemia can cause moderate alterations, whereas prolonged hypoglycemia can cause tissue damage and even the brain death. And that is why we have to be ultra careful on these lines. And that's why you have morbidity of hypoglycemia causing neurological abnormalities like coma, convulsions, transient motor sensory deficiency, ataxia, chorioathesis, permanent brain damage, sometimes intellectual impairments, cognitive dysfunctions, behavioral abnormalities, cardiac, we already seen myocardial infarction or arrhythmias, vitreous hemorrhage in the retina, or sometimes you have fractures due to convulsions, accidents or other things. It have direct costs which everyone knows about, maybe emergencies, admissions, frequency of monitoring, physician's visit, hospitalization, but indirect costs like absence from the work, your productivity comes down, it may cause you accidents, work disability, and reduce work capacity. Treatment of hypoglycemia, very simple rule of 15. Monitor blood glucose, give 15 gram of glucose, wait for 15 minutes, again recheck it, and again till it comes to normal. But if it is mild to moderate hypoglycemia, if it is severe hypoglycemia, you have to ultimately administer intravenous glucose or dextrose to control it. This is a basic patient education strategy for hypoglycemia. If it is a sulfonylurea related hypoglycemia, it cannot be treated with glucagon. It has to be through the glucose. Alcohol, as I told you, can cause hypoglycemia because of reduced gluconeogenesis and glucose production by the liver, and therefore predisposes to hypoglycemia because of alcohol may be delayed and prolonged for multiple hours. Beta blockers may mask the warning signs of adrenergic symptoms. It actually inhibits the sympathetic mediated glycogenolysis and gluconeogenesis, and it can also delay the recovery from the hypoglycemia. Nocturnal hypoglycemia, we already talked about the arrhythmias and dead in bed syndrome. Hypoglycemia unawareness. Now it is more common in type 1 diabetes. Patient actually doesn't recognize the hypoglycemia. The hypoglycemia threshold by the central nervous system goes down. They don't recognize the hypoglycemic symptoms till they go for, ideally everyone gets recognized it at 70 or maybe 63. But once you have hypoglycemia unawareness, your threshold goes down and you directly land up into neuroglycopenic symptoms. And which are these individuals? Most commonly type 1 diabetes. If they are very strictly controlled diabetes, and if you have frequent or the recurrent attacks of severe hypoglycemia, precipitates hypoglycemia. So it is hypoglycemia, recurrent attacks of hypoglycemia, which precipitates hypoglycemia unawareness, and a threshold further goes down. Usually these patients with type 1 diabetes or long duration have autonomic neuropathy as one of the hypotheses. Somogi, I feel everyone knows it. It's an iatrogenic hypoglycemia that you give high doses of long-acting insulin in the night. You have 3 a.m. hypoglycemia, you're fasting hyperglycememia, you reduce the long-acting insulin, the 3 a.m. hypoglycemia disappears, and then the Somogi effect gets corrected, and it is Somogi effect. In contrast to that is dawn phenomena, which is because of the counter-regulation related hyperglycemia. And that's why every one of us, whether diabetic or non-diabetic, between 2 to 3 a.m., our blood glucose is lowest. So if you are on glucose lowering therapy, we recommend that every person with type 1 diabetes as well as type 2 diabetes on glucose lowering therapy should monitor their blood glucose at least once in a week at between 2 to 3 a.m. to avoid Somogi phenomena. Hypoglycemia in pregnancy, traditionally blood glucose less than 60 or 63 with typical symptoms of hypo is called as hypoglycemia in pregnancy. Neonatal hypoglycemia, we call it as less than 30 milligram in the first 24 hours of life. Now, hypoglycemia in pregnancy is more frequent during pregnancy versus the non-pregnant women, and occurs around 35 to 70% of the pregnant women who require insulin. Blood plasma glucose during pregnancy are almost 20% lower in normal pregnant women, in women with GDM versus the non-pregnant women. Maternal hypoglycemia can cause fetal hypoglycemia, fetal pancreatic hypoplasia, and these offsprings are likely to develop diabetes in the adult life. There is another terminology in pregnancy, now they call it as masked hypoglycemia. Masked hypoglycemia is defined as an interstitial glucose level less than 50 milligram for more than 30 minutes without any symptoms, which is detected in CGM. So this is another thing which we need to. Women on insulin therapy, 40% of these women had masked hypoglycemia, and 10% of these women had glucose levels less than 40 milligram, suggesting a lower threshold for developing hypoglycemia. So women with pregnancy have lower threshold for they can sustain hypoglycemia for a longer period, and it does not have HAPO study, ECOI study. These are two classical study or landmark study in pregnancy diabetes, and they have documented that hypoglycemia is not of big concern, not big concern in pregnancy. Observed in women GDM treated with insulin, more common, more than 90% hypoglycemia events were nocturnal. The food for thought about hypoglycemia, which is more frequent during pregnancy. It has been hypothesized that hypoglycemia during pregnancy can be induce adverse events like fetal malformation, small for gestational age, and poor neuropsychiatric development. The association between the level of hypo and embryopathy remains uncertain. However, very important, ACOIS and HAPO have not addressed the risk of hypoglycemia and its effect on the pregnancy outcome. The reported evidence of hypoglycemia varies in different studies, and this is because of the hypoglycemia can be asymptomatic in pregnancy. CGM data has come out with a magnitude, duration, frequency of glucose fluctuation or increased glycemic variability is equally important in pregnancy diabetes. So first in the second half of the pregnancy and postpartum type 1 diabetes, the hypoglycemia in type 1 diabetes, it has been shown if you use insulin analogs, the risk is less in type 1 diabetes. This is the clinical implication, this is the only paper presented on lipohypertrophy. We have given insulin at the lipo site versus the normal site. The lipohypertrophy is an accumulation of fat at the repeated insulin site, where when you go on taking insulin at the same site. And this here, when you take the insulin, the absorption of insulin is low, and then it causes a lot of glycemic variability. And unfortunately, no one of us, many of the time, don't observe the insulin site. We go on increasing the dose of insulin. We should inspect the site of insulin injection and detect lipohypertrophy. The incidence in type 1 diabetes almost 69% in Indians and 30% in type 2 diabetes. And this is lipohypertrophy in the thighs. This is gluteal lipohypertrophy. This is abdominal, and this is again abdominal, and this is forearm lipohypertrophy. And this is the glycemic variability in the first day 2, and once you correct it day 14 on the second below the lower graph has when left another 7 days when the insulin was taken the normal tissue, and the above 7 days when it is high glycemic variability. This again shows the lipohypertrophy causes increased risk of glycemic variability, unexplained hypoglycemia, and every clinician should check the insulin injection site at every visit, preferably at least once in 6 months, and people should be educated for insulin injection technique. So we should start as a clinician thinking about lipohypertrophy. To conclude, my hypoglycemia has a major pathophysiological, psychological, and socio-economic impact, and it's a dreadful experience to the patient. Unfortunately, it is often unreported. Causes the considerable cardiovascular morbidity and mortality. Rare of the hypoglycemic episodes increases with rate of hypoglycemic episode increases with tighter blood glucose control. Frequent attacks of hypoglycemia in type 1 causes cognitive dysfunction. Better is to treatment of hypoglycemia is prevention. So education becomes a key here. So education for prevention of hypoglycemia. Before I stop here, wish you all a happy Earth Day, which was 22nd of let invest in our planet, eat local, eat seasonal, avoid food wastage, and plant a tree to celebrate Earth Day. And before I stop, wish you a happy Eid Mubarak, which is again yesterday, and a happy Akshaya Tritiya on a very, very auspicious day. Always celebrate your birthday, your anniversary, or Akshaya Tritiya or Eid by cutting the fruit and not cutting the cake. Thank you very much for patience listening.